Welcome, Jan, welcome to the rest of the team. This meeting, as you know, is one of a series of public accountability meetings with all health organisations in Wales. So you have with your board and members of the Welsh Government senior executive team here from the Health and Social Care Department. There's a lot of people in the room, but my suggestion is that rather than go around the table introducing ourselves, it's the first time that each person speaks. If they can introduce themselves, that would be helpful, but only the first time. We need to keep doing that. The meeting, as you can see, is being live streamed, so the public can view the meeting. There'll be a recording of the meeting available on the Welsh Government YouTube page after the meeting as well. We have translation services available, so we could run in against share. Please feel free to speak in Welsh or English as you prefer, and there's translation for those watching as well. So we are going to cover 4 areas, as you know, in this discussion. Firstly, finance and planning. Secondly, how the health board is improving access. Thirdly, how the health board is delivering services ready for the future. And then lastly, how the health board is being run. We've provided a detailed evidence pack, for which thank you. So some of those areas have been covered in more detail with more assurance in the pack. And so we'll be focusing in the discussion today on areas where we're looking for greater assurance. So that may mean that we focus more on challenges than on successes, but there's obviously also an opportunity for the board to set out its position, as it were, at the start of each of those items. A number of the questions which I and colleagues will be putting are informed by correspondence that I've received from the public over recent months. And at the start of each of those 4 areas, it would be helpful if somebody from the board could give a brief introduction to the theme from your point of view. I would just say, without wishing to be rude, brevity is appreciated. And at the 4-minute point, I would be encouraging colleagues to conclude their remarks. That's only because there's a lot for us to discuss, and I think it's more helpful to have a discussion in the room. So before we get underway, the 4 areas, Jan, is there anything you'd like to say about your opening remarks?
Thank you. Cyfeillion Bwrdd Iechyd Prifysgol Bae, ysgrifennydd y cabinet a rhan y bwrdd diolch am y cyfle i'ch cyfarfod chi heddiw. So the board welcomes the opportunity to provide a public account of the way in which we discharge our leadership and governance role. We practice open governance, and we are here to set out our challenges and the actions we are taking to improve. We do not underestimate those challenges that fall into 3 categories: operational, strategic, and structural, and we will touch on all 3 today. In the past year, we have strengthened our governance and accountability from the board to the front line. We have reviewed our board, committee, and cross-committee governance. We have redesigned our performance and accountability framework. We have overhauled our risk appetite and management, and we have refreshed our organisational strategy. We have begun our structural change through Organised for Success, strengthening clinical leadership. We are preparing to update our clinical services plan, and we are bringing in a delivery unit. So all these steps have strengthened our grip and control, and we have taken ownership and responsibility for, together with making progress in our key challenges. We remain deeply sorry for the harm and trauma that some women and families have experienced in recent years in our maternity and neonatal services. And we have set about implementing the recommendations of the independent review, the health and family reports, with pace, with compassionate leadership, and with determination. We are driving improvements in mental health with a transformation programme underway. We are rolling out digital solutions. We are undertaking urgent estates work, whilst we resolve the need for new capital investment. We are tackling unscheduled care from end to end, working with partners to reduce handover delays, overcrowding, and waiting times. On planned care, we are maintaining good performance, and we are pleased to support the always position by extra work. We are deepening our partnership working with local authorities, health sector, primary care, other health boards, and national bodies. We are committed to optimising regional working, and we are building services around people, prevention, and place in line with community by design. Above all, we have a forensic focus on reducing our financial deficit that we know is unacceptable and returning ourselves to financial and service sustainability. We have significant work still to do to achieve a sustainable position, and our external partners are working with us on the drivers of our costs and the focus of our work. We are undertaking all of the above in a context in which poverty and deprivation across our communities are the biggest drivers of poor health outcomes. Cancer and cardiovascular mortality, increasing frailty, and patients with multiple complex conditions. We are responding with innovation, with pathway redesign, and investment in digital solutions. We are, however, constrained by a state that is compromised and is a barrier to modern, effective healthcare delivery. We are also on too many streets. So, as Committee in the Cabinet, we acknowledge and we own our journey. We welcome scrutiny, feedback, questions, because accountability drives us on. The expectations of our population are rightly high, and we are determined and we are ambitious to meet them. Diolch yn fawr.
Okay, diolch, Jen. Thank you for that. And there are a number of points in there which, as you all understand, you'll want to come in and discuss in more detail on the call for the next 2 hours. I want to start with finance and planning. The board's in level 4 escalation in relation to those, and as you've already acknowledged, the deficit position is not acceptable. Who would like to read on that?
If I may, I just wanted to make a couple of very brief introductory comments as the accountable officer. They're helpful, and then I'll ask Pat, our chair of performance and finance team, to give an IM's perspective. And I wanted to start with the planning piece. So I think one of the things that we have acknowledged and we are addressing is the need to strengthen the approach to planning. I think some of the challenges that brought us to where we are today is that we haven't necessarily aligned well enough our planning in relation to service, finance and workforce. And so that some of those things don't triangulate in the way that we need them to. So we're building a new approach to our planning, and that's embedding and it's informing our plan for this year and will inform what we do next year. And really that's about putting patients at the heart of it. So coming at it from a quality and safety lens in terms of how we plan. One of the other things we've done as a board is really make sure we're looking at 3 time horizons. So present forward and future back, to make sure that we're putting in place the milestones we need to be sustainable as quickly as we possibly can be as an organisation. And then turning to the financial position, we accept we're in an unacceptable place at the moment, and we are really driving forward the plan for this year to get us to where we need to be. We've taken further decisions this week as a board that have been through our scrutiny process to firm up tighter actions and grip and further actions in terms of pushing ourselves forward. And we recognise we've got risks that we need to manage going through that. We are confident that we will get to the 54.5 million saving that we set out in our plan, and we'll be able to describe some of the detail that's behind that in terms of achieving that. The work that we're doing with our partners, helping with the underlying position in terms of detailed and in-depth understanding that will help our plan for next year. And when we come on to it a bit later on, we'll share more about how we're using our clinical services plan to set out how we will deliver and transform our services. We're acutely aware as an organisation we need to be much more rapid and more radical in terms of how we deliver that, working with our communities and our staff. In relation to many of the areas of escalation, we are making progress in most areas. Our commitment is to make sure that we're sustaining that and it is sustainable moving forward. And hopefully that's what we will walk you through in response to the questions you had today. But Pat, in terms of chair of the planning, performance and finance committee, we meet very regularly and you have plenty of chance to look for assurance and question us in depth. Do you want to have a couple of minutes?
Sure. I'm Pat Price. I'm independent member and the chair of Finance and Performance Committee. The committee meets monthly, but we've been meeting more often as needed to seek assurance on financial delivery and performance. In light of the financial plan being off track, we've increased meeting frequency and the levels of scrutiny we've gone to. Lead execs and service group leaders attend regularly as required, and deep dives are undertaken into areas of concern. We recognise the need for greater focus on an integrated finance plan, including transparent reporting of our underlying deficit and the impact of non-recurrent savings. We welcome plans to strengthen decision-making around governance, benefits realisation, with a clear rationale for choices, with tracking of impact and savings. Long-term financial sustainability and the level of savings that are going to be needed to deliver it will require whole organisational transformation, and we welcome plans to strengthen decision-making, delivery support, performance and accountability. Performance and finance see the embedding of the performance and accountability framework in quarter 1 of 26-27 is absolutely critical, alongside the kind of data insights and intelligence through the delivery unit approach that's going to be taken and the implementation of the Organised for Success programme. The committee will continue to provide rigorous oversight, challenging where needed and supporting where appropriate to ensure recovery actions deliver impact. Our commitment is to maintaining clarity, grip and transparency as the organisation moves.
So when you have a situation which the board is in where you are very, very wide of where you need to be on information, generally the question is that about poor planning or basically failure to deliver? And I think I'm hearing from what that you're saying that it's poor planning. So we've had a situation in the last couple of years where the board has been very wide of where it's needed to be. That hasn't always been the case. 3 years before that, it was in balance in the year. So what I want to understand is, since that is your analysis, what in practice does that mean? What will be changing? What does a new approach to planning look like? You talked about some of it's about cost control, but scaling of this challenge is beyond tighter cost control. So what does that better planning look like, and how will it? How quickly is it going to be in place?
Do you want John to come in first, John?
Sean, I'll come in first and then I'll be with Darren.
Yeah, thank you for listening to you. We're just going to start off.
Just introduce yourself.
I'm sorry, it's Darren, the director of obviously it's possible as well. And the challenge has been largely around our delivery of recurrent and non-recurrent savings as a base in the organisation. And as you pointed out, in 22-23 we were a balanced organisation. But over the last 3 years, we've delivered 130 million pounds of savings, but only half of that has been recurrent. So around 70 million of the current problem has been sat through our challenges in terms of delivering that recurrent change in the organisation and planning process that we've commenced and are adopting for next year in particular. Uses the underlying deficit analysis that our strategic partner board shows us where the opportunity is, and we're targeting our activities to introduce sustainable change against those areas. I can go into detail if you wish in terms of where those areas are.
So you're basically was it's a failure to identify recurrent savings.
It's a fundamental part of where we were doing narrowing the cost for us as well as the different international norms and continuing that together in drugs in particular. But the recurrent savings has been a big challenge for us in the
Just to follow up on further, so there's something around, so your evidence paper self-reflects, so you made investments that have been affordable, but decision-making processes need strengthening on governance benefits realisation and the rationale for those decisions. So I recognise that as point on recovery savings. I think our assessment would be there have also been investments that haven't resulted in expected benefits. So there's two questions that fall out of that. One is, what were the shortcomings of the previous approach? And then secondly, what are you doing to strengthen the issues you're addressing and you're highlighting in your evidence?
Pick that up, Dan. So we have been through every line of that analysis in terms of the additional money that's gone in. And as Darren said, the lack of recurrent savings is one side of the equation, and putting too much money in to shore up in terms of some service pressures that we have put additional staffing into, and some investments that we've made, as you quite rightly put out. And there are a range of different things in there for different reasons. So this comes back to the issue around workforce planning. So when we've gone through and analysed line by line where that investment has gone in over the last couple of years, 2023, 4 and 4-5 in particular, a lot of that has been about addressing service pressures, but without transforming the service. So we've been shoring up services in the way they're currently delivered. So we have put more workforce in, and it has delivered benefit in terms of the dials moving in a lot of areas, but actually what we need to do is much more radical transformation of how we deliver that service. So quite a bit of that investment's gone into the unscheduled care and emergency care system. So shoring up ESDEC, putting in our older persons assessment unit, putting more medical staffing in to shore up the front door and make sure we've got more clinicians available longer into the day and over the weekend. Which has delivering us slowly improvement in our ED service. But what we need to do is more radical transformation of the pathway so that we are keeping our length of stay short, we're getting patients out more quickly. And so against each of those lines, we have forensically explored what we got as a result of that investment. Some of that has delivered benefits. So if you take the medical workforce investment, on one side of the equation, we put funding in, but we know that that did reduce our agency spend that was much more ad hoc and not planned for in terms of our workforce for front door and ED. What we accept is that the plan didn't, the way that we did our planning didn't enable us to really join the dots up in terms of our performance data and our metrics in terms of what that's delivered, and we didn't have a robust enough process of tracking those things through. So they've gone in as lots of lines of investment in lots of areas of our service. We've got a new process around investment and decision making, much more grip in terms of how we assure ourselves that any benefit that's been articulated as part of the plan is absolutely explicit in terms of investment going in, and that we make decisions if we're not getting the return on investment, we make different choices. So there will be some difficult choices that we are looking at in the remainder of this year and into next year, where money has been put in to shore up services, but it hasn't yet delivered what we're anticipating.
So on that, are you then looking at examples? I mean, you could make this argument in emergency care. Actually, I mean, historically, a huge amount of money have gone in, and historically haven't, frankly, moved the experience for patients. I mean, that's changing, obviously. We'll come on to the detail of that. But that's certainly been a picture in the past. You're making different choices now. So would you, as a board, be looking at a situation where, if there have been large amounts of investment and you haven't been able to identify an improved picture as a result of that, that you withdraw that investment?
We would need to take a risk-based approach to that, and that's what we're doing with all of these, because some of them are, but most of the investments are in people in our workforce, and they're in jobs and roles. So we need to work that through and take those decisions and then work that through from a workforce perspective. But the board has, as part of its risk assessment and risk appetite, considered that we will have to do some of those things. We will have to make some really, really hard choices, and the board has committed to doing that. Some of the issues are, go back to some of the structural changes that Jan made, and again, we need to make sure those things we can unpick and change much more rapidly than we've been able to do in the past.
I'll just add to that, Secretary, I'm sure we'll come on to it. But today, we have 8 wards worth of patients clinically optimised who do not need our care. And we have people who are living in hospital because they are homeless. And you know very well this agenda because you see it through the national leadership group that you have. It is a partnership approach, and you'll have heard me talk about the West Glamorgan Regional Partnership Board together with the chair, Steve Hunt. This is a system-wide issue, and this is one of our biggest drivers of the deficit. And Darren could exemplify, what we would achieve if we didn't have 8 wards worth. Okay, and that's why we haven't been able to make those savings happen, because we can't get the return on investment out. One of the other things we will be doing, because I'm sure we'll come back to clinically optimised patients, but we might want to talk about what Performance and Finance will be doing using the underlying deficit report when we get it in its final form, how you will be overseeing that drive against investments made to date and how we will be ensuring that return.
Yeah, sure. I mean, we have we've done a lot of work working on the recovery and sustainability programme, and it's very forensic, sharp focus on what are clear areas of cash releasing savings. And as we're moving forward, going into a no investment plan that is going to be built around the drivers of that underlying deficit. So there's those 5 or 6 areas, and of course the absolute critical priorities for the organisation. And so we will be looking at ensuring that there are actions in place, that there are milestones that we're monitoring and that we're keeping on board with that to make sure that it is delivering in line with the plan we've given. So they will have a very forensic, very high level of analysis on that as we move forward.
So That's good to hear, obviously. But if I was a member of the public, I'm going to be listening to this conversation, I'm thinking, well, there isn't a huge amount of money available, and there isn't vast amounts of new money likely to come in the short term. So you're talking about investment choices that will also involve reallocating spending from what you're from other
Disinvestment trusts, yeah, absolutely. And it's a whole, I think what we haven't grasped big enough is the fact that this is a whole organisational change transformation programme, and that it needs to be addressed as such. And I think we've had gaps in delivery capacity, delivery capability that helps the executive, that supports them with driving this at pace. And we're definitely looking at dealing with that. That's something that's been.
The other thing for us, of course, Cabinet Secretary, is productivity and efficiency. We have major gains to make, and perhaps Deb can say a little bit about where we are at work on those, because that's one of the key drivers of our deficit as well, alongside our workforce issues, which I'll then ask Tina to come in on. Perhaps Deb can start with productivity and efficiency.
Before we do that,
Oh, right, okay, sorry.
Good afternoon, everybody. My name is Jacqueline Totterell, and I'm the Director General for Health, Social Care and Early Years, and Chief Executive of NHS Wales. I just want to go back to that bit about 8 wards of patients who are medically optimised. So I come from the point that I think that there's always a solution to something. And so I suppose my question is, what have you begun to explore with your partners to actually begin to enable the citizens who are there in those 8 wards to actually be in the right place earlier than they are already? Because no doubt you will see them de-optimising if they're in the hospital bed for too long. So that's the bit. If that's driving some of the bit both around money as well as patient harm and outcome, then that is a place to actually really go.
And ask Deb to come in on that, Cabinet Secretary.
Afternoon, I'm Deb Lewis, I'm Chief Operating Officer. Just on that bit, we're doing a huge amount of work with our local authority colleagues. We've fortunately only got 2 local authorities really that we deal with in the main, and the clinically optimised conversation is forefront in all the discussions that we've had. What we do at the moment is we meet weekly with directors of social services to go through lots of issues, but generally that's at the top. We've got a communities and older persons programme board that is jointly chaired between Director of Social Services in Swansea and my deputy in the health board. We've developed a live dashboard that has all of our clinically optimised patients in there, so they can see where they are, why they're delayed, what the length of the delay is, and what's happening to the next. That is accessible from all partners, and we do weekly meetings on all of our long length of stay jointly with local authorities to make sure we're all in the line to move forward. From the delays perspective, you're very chatting that those numbers were heading down. Today is 173 in our beds. That's reduced from Monday when there was 190. I'd like to say that because patients are moving, but it's not. It's because they become not clinically optimised due to the delays that they're experiencing. So we know causing harm by these delays not happening. We are going to be starting to record any harm for those patients to make sure we can evidence what's happening with those and what the next step for those patients are as well. But we really focus with how we can manage the patients better. On the 5th of January, at the moment, those patients are spread across all of our wards, and generally there's about 4 or 5 maximum patients on ward. They don't do well, they don't get the best focus, and it compromises what the ward tries to do with its legitimate patients on the ward as well. So we're cohorting the first 30 of those patients in what we're going to call a clinically optimised ward. In an empty ward, we've got a Singleton hospital. That allows us to change the staffing model in there because they don't need medical input or shouldn't need medical input. They will have a name consultant still because they're still under general care, but they won't be under active medical intervention. There'll be a different nursing model, strengthened therapies model, and with designated social worker input. So all of those core components we're trying to bring in.
So you've got one of the best quality estates in Wales, I would say, which is excellent. And the bit I was going to push you a bit more on is actually how are you reconditioning some of the patients that you're able to enable them to get home support rather than into a home, and how are you doing? There's a bit here about what further partnership, because you want to do differently with social care, because if we keep doing the model of this is what we've got, what are you going to do about them? Actually, we'll keep getting what we've currently got. So it's just about rethinking some of that in a very different way. And you are looking at going to.
You might have a online house as well.
Yeah. So the investment we put into the UC system, a few years ago, was on the premise of reducing opportunities to reduce the bed stock by changing the front door, failure access and the community offer alongside that. So those services are really pivotal. We know they're the right things to do. Unfortunately, the clinical officers numbers haven't changed much to enable us to do the bed reduction. But what we've got at the front door now, so we've got an integrated discharge hub that focuses at the front door as well. So it prevents the admission for those patients who don't need health care. And those social admissions are really high volumes. They're very complex when they present, and then they become even more complex when they're in the bed. So as far as we can, we're trying to turn those patients around, linking in with local authorities, emergency social care, to make sure we move those patients on. That is bedding in, it's going to improve.
What contribution percentage terms to the overall deficit is this issue?
If you look at our underlying deficit report, and we're just checking out some of the benchmarking that would indicate that we, I hate the term, are over bed capacity by around 230 beds. So if you take that in the system, and we've got 173, is it today, Deb? You can see that taking those beds out and equalising and right-sizing our beds becomes very difficult when we've got that many beds.
So I'm asking some questions. So you're just saying the approach to plan, which is more clarity on the cost implications of various interventions. I'm just asking what percentage of your deficit is attributable to this challenge.
So it's 15.6 million of the 95 stated in land grants.
So there's specific issues causing that additional pressure.
Yeah, so I introduced myself, I reckon, because I committed to the standards and other director of finance. So once you recognise the unacceptable nature of the deficit, you're also challenged to hit that position in year, and obviously you've had some good interactions on that all year. I'm mindful your monthly position has landed since the evidence pack, so it's useful to understand what is your current savings gap that you're still to find. And secondly, what are you going to do to ensure that delivery is recurrent to avoid the cycle that we rehearsed at the start of the meeting?
Dan will fill in on that.
Thank you. So in that stage, we reported a further 4.2 million deficit increase, so a further 51 million to the deficit in total. We've made progress on the savings plan as well. So if I specifically look at the savings plan, 55.4 million target, 42.4 million identified and planned with a 13 million gap. Within the 42.4, 33.8 million of that is clear savings change plans. And there's 8.6 million of run rate and spend that we're managing. So they were featured heavily in the tracker, but they're guaranteed within the beginning. So we're incredibly confident on our 42.4. We are now working on this 13 million gap. It's a recovery sustainability board meeting about a fortnight ago. Performance events committee meeting on Tuesday of this week, and a special board on Tuesday this week to receive the outputs of that. And that will get identified further 11.7 million pounds of plans that we've got against the 13. Leaving us with a gap of 1.3 million. There are 4 lines of inquiry then to further close the 1.3 million. We're looking to mitigate that over the next couple of weeks, specifically around further variable pay improvement. The investment we've touched on, we're expecting a report back again in December on a review of our community services, which they're touched on in the address. We think there may be service duplication next week after the services up in pillars. There should be opportunity to improve that investment back. We're also looking specifically at level of theatre activity in the last quarter, protecting the 104-week cohort with delivery, which clearly we will share, but there may be opportunity to re-cohort the element theatres configured and reduce cost further. So that's how we're trying to manage the closure of the gap. We've gone from 13 to 11.7 down and the 13.
I will just come back in, but yes, but you
I just want to say, clearly from the board's perspective, the board has to have a level of confidence in delivery, and we rely heavily on the Performance and Finance Committee. So you might want perhaps to just talk through how Performance and Finance assures the board around confidence in delivery.
I will want to do that. I just want to make sure that there isn't a follow-up question on that point.
So I think we've been in a bit of a cycle all year of the actions the organisation will take if they're not successfully achieved. So I'm mindful it's December. So there are plans to close that 13 million gap for 11.7, probably the most challenged period of the year. So what confidence can we have that those actions will actually deliver this time?
I don't think after that.
They're a very different nature of control. They're kind of system block controls almost. So you know, we've worked with enhancing controls, and many of those have started to have an impact. But given we're coming to a very difficult quarter of the year, that we've put complete system block controls on now, and that's what gives us a greater level of confidence in these at the moment.
So recognising the nature of this discussion and the fullness of the delivery agenda, planned care, winter challenge and so on, if you've got system block controls on things like that, how are you going to manage financial delivery alongside delivering of all the other performance expectations?
Liz Ricks, Lecturer in Nursing, and of course variable pay, we are this part of the work goals. And we have worked really hard to put our controls in all year, and we know that we've got good controls in place the way that we were actioning variable pay. However, we've come to a point now where we have to change the action that we're taking. And from a system block control perspective, we know that we have no vacancies, we have a workforce that is evidence-based for the Nursing Care Act, and we have high unavailability. So we're really challenging that unavailability. It's taken us time to understand the drivers of that, and the support that we've had from our external partners has really helped us to focus. So I meet weekly with a Nursing and Midwifery Workforce Board. We see all of that information, so the actions that we now are taking are different. So we will deploy bank, for instance, in a very different process to the way that we have previously. So we will do that centrally, and we'll do it based on need, but just on understanding what that need is helps us to cap what is available to the whole organisation. It's taken us time to get to the understanding that we now have. And what I have got is service group nurse directors who are absolutely engaged and on board with this. You can't do something like this without the leadership in all of our service areas. So we're confident as of this week that that usage will change.
Thank you.
Yeah, thanks, Cabinet Secretary. Neil, the Deputy Chief Executive of NHS Wales. So can I just go back a little bit to the sort of underutilisation of your bed base? The fact that you've got 170 to 190 delays. Your delay numbers have come down quite considerably this year. I think it's 40% reduction in days delayed. But as Dan has alluded to, it's what, 16, 17 million pounds of your cost issue. How much of the delay or the issue with discharge is in your own hands, and how much of it is as you referenced, the partnership issue? Because we normally find it's 50%, that's the sort of the broad average. And it probably links to where you are with variability that drives efficiency in overall terms. So I think on your enabling actions, there's 4 or 5 that you've rated red, so they've not been delivered in overall terms. About 14 that are amber. The efficiency that you could drive there for yourselves, reducing variability, utilising best practice, is in your own ear. So I just wonder where you are with the actions to drive that, because that's clearly, you know, could be 7, could be 10, could be 15 million pounds of an issue you can drive out. Really.
Yeah, if I can on that one, thank you. The one sense, so the clinically optimised number varies between local authorities, so we've got different issues between the two, and we focus on those issues between the two of them. And I would say out of the reasons for the delay, look at the pure numbers in there, I would say it was mostly 70% delays discharging out rather than assessments internally. Outside of that though, you're right, we've got to improve our own processes to get the patients who are not clinically optimised ready for discharge sooner. And as part of the reset week, all of our execs supported and went out on the shop floor, visited all of our board rounds, and there's a bit of a mix on how effective and efficient those board rounds are. We've done some very focused work with some of our medicine board rounds, and you can see that work now coming to fruition and really clinically led and driven by a consultant with a therapist in that board round, and really starting to get the traction, and the length of stay on those boards is changing. We can see that. The wards that we've still got that work to do, because it does take time. There's a lot of bed and change and different culture on the wards, and we can see where the gaps are in that. So we're really cognizant of the work we still have to do from a health perspective to making sure that we're not over-investigating, we're not over-treating them, and a patient will benefit no longer from the hospital service, that we have to move to a discharge plan. And we're having some successes across that bit. Just, I think that bit is 50-50, Nick, that we need to mix on. And obviously, as I said earlier, it's the preventative bit to not admitting the patients if they don't need hospital care. That's the other critical factor for us.
So just to kind of briefly just come back. So I totally get all of that. We did all of this last year in the 50-day challenge. And exactly the same things that you described we've done now were done in the post-Christmas period. I think it wasn't in the run up to Christmas last year. What stopped it being a continuous piece of work that continued right the way through the year? We want to go back to execs going on the boards, Welsh Government issuing do a sprint, fortnight. I'm just, because I think everything you said is correct, but we seem to go around this circle every year.
Yeah. I would put on our reset week was set before the reset sprint fortnight, so we were online with that one, and it was good that it coincided. Yeah, we are. I think it's about embedding and changing the culture on the wards. It's not a quick fix. You know, what we've done since last year is implement an integrated discharge hub, so we've got a team of focused experts to help the really complex discharges. I think what we tried to do last year, and you're right, our numbers changed radically from last year, but that's from a very poor starting position. And we were the worst in Wales last year. Right. We're now not, and our improvements are in the mix with it, but we still got the same challenges as everybody else. So rather than try and make every ward expert in complex discharges, we've implemented the integrated discharge hub who will manage those complex patients across the health and social care. The nurses on the wards will deal with the more straightforward discharges, and those patients who don't become clinically optimised, our length of stay actually is very good, and those patients are turning around in a good way. So I think that's the difference from last year, is how do we embed the culture across the organisation, not being focused just on Morriston Hospital, because that's some of the we end up into as well. There's an important role for East Talbot in some of that movement as well. So we're working across the whole system, I think, is where we're focusing on it differently. You're right, some of the issues are still the same, but we will work to change them.
Finally, everybody soon.
Thank you. Sue Tranker, Chief Nursing Officer. I'm wondering, you talk about the wards as a homogenous whole, and you know that that's not the case. What are you going to do with strategy and clinical leadership across your wards that we can start to address some of what you suggest is very cultural and behavioural issues? So it'd be useful to know what are you doing, what you hope to see by Easter, and when you want to do another sprint again.
Thank you. Yeah. So thank you very much, Richard Evans, and the executive. So that's a really good question. So it's multi-professional, isn't it? It's not within one group. We need that strong leadership across all the groups, whether that's medical, nursing, or indeed therapies, because each of those groups plays a key role in understanding what the patient needs and what the route out of hospital is. So there's several things that we have done. Some of it being independent, some of it being as multi-professional groups, in terms of fostering that culture of leadership on or supporting clinicians to make those decisions. I think while we have focused a lot on the clinical, formal clinical leadership roles, we are also looking at how we strengthen that leadership at the coal face, at the ward level, because that's where it's key. And one of the things, I suppose, in terms of that clinical leadership that may have been lost over a period of time, is that the ward sister rules and on his or her ward, and the key role that that individual plays in coordinating and acting on behalf of the patient advocate in what they need next. So what Liz and I have been looking at is how we do strengthen that across all those clinical and professional groups on the board, and support them to develop that different way of working and to get it embedded and included in the system.
You've articulated the objective, but I still don't know what you've actually done about it. So give you plans and steps.
So Richard's right, and thank you for acknowledging the key role that a nurse leader would play in coordinating care for a patient, although it is multidisciplinary. I think firstly, we have to set very clear expectation of that leadership, and we have to hold to account that leadership. So specifically from my perspective, with the cohort of professionals that I have responsibility for, it is regularly engaging and meeting, setting the expectation, and then following up if that doesn't happen. So Sue will know, for me, the key leaders there, well, your board leaders and your team leaders, doesn't matter where they work. And we set up a process where we come together on a monthly basis. Not only go and visit them where they work, but we come together. We set development opportunities to align with the priorities that we now have. The engagement is key in this, and the communication of expectation is absolutely crucial.
just very briefly come back. And from a medical perspective, we have several fora which our medical leaders attend. Similarly to the nursing, it's establishing this is what we're going to do, and we're all going to agree that we're going to do it in a standardised way. So it's agreeing a standardised approach. Everybody's on board with it. Now, clearly, that is a work that needs to be a work in progress in terms of different degrees of engagement, different willingness, and that's something that we then support our clinical leaders in driving forward within those clinical teams. We had the meeting with the top 100 this week and had conversations along similar lines with the top 100 leaders in the organisation, agreeing that it's really important to set out, next point, this is what we said we're going to do, this is how we're going to do it, and we're all going to do it together and to hold each other to account for delivering things in that way.
Thank you. John, we're going to move on to the second item, which is about access and quality, which your team has been a good job.
Yeah, thank you. I can do the same thing, if that's okay. Just a couple of words, and then actually last week, you showed our quality and safety words. I guess our focus on this is to look at this through the lens of safety and quality. And so access is all about making sure that we are delivering the best possible access, and that we recognise that harm can come to patients if we're not delivering that well. I guess this is an area where we've touched on some of the points already, but in terms of our plan care, we are committed to delivering and pushing further where we can, and in the way that Deb's described some of the productivity and efficiency that we're pushing really hard at, particularly where we know we've got some pinch points in the system. I think I was going to mention the emergency and urgent care system, but I think we just touched upon that. So for the time, I will skip over that. One of the areas that we do know is challenging, that again, we can come back and answer questions on in relation to cancer. We are making progress. We've hit the 60% target for the last 3 months consecutively. We know where the challenging pinch points are, and we're working through those and as quickly as we possibly can. There's quite a lot of work in this space around strengthening mental health. You'll be aware of some of the discussion we've had around our transformation programme around mental health and ensuring we are hitting all of the access targets of mental health, and we've still got some challenges in relation to some of our cancers in particular, to ensure that children and young people get timely access. We're working that through with the service group at the moment. Richard, I guess one of the areas that you're giving a particular focus to is hospital-acquired infections, where that's been really hard to shift the dials at the speed at which we want. And so again, we're making some very focused work in relation to that. But Jean, from a quality safety, many of these issues come up both in the performance committee, but they're also seen through the lens of quality in terms of good patient access to our service. And whether we want to give a couple of comments.
Yeah, please. I'm Jean Church, the independent member and chair of the Quality and Safety Committee. Delays and communication about waiting times are obviously featuring prominently in our complaints and patient feedback. That feedback is heard and is also shaping our actions in the future. The reducing waits is a key quality and safety imperative for us. We're using both outsourcing and insourcing where appropriate, while driving efficiency and productivity to deliver more capacity and better value for money. The Quality and Safety Committee has been reset with a new work programme agreed with the Executive Director of Nursing, or to me that's Liz, ensuring patient safety and experience are centre stage for us. We are also embedding a strong culture of accountability and continuous improvement. No longer are we accepting of committee papers that give us the metrics. We are deep diving into those metrics to understand the themes and opportunities that we have to ensure that we, as a committee member and both as board members, actually know what is really going on behind the papers and the metrics that we are delivering. We now receive regular reports from the newly formed Perinatal Committee with a standing item to the board, strengthening oversight of maternity and neonatal care, and our integrated performance report triangulates delivery, quality, finance, and workforce, giving us a single, transparent view of progress and risk. We're determined to keep improving our access and quality and to hold ourselves publicly to account for the results that we achieve.
I mean, you touched on emergency department performance, and we have spoken about that, but I wanted to explore with you the improvements in terms of length of stay, in terms of the longest waits coming down, and there's been improvement in handover, although that is now starting to creep back again. We discussed a few months ago just how fantastic the improvements have been in Morriston, and I want to understand what the board's view is of whether those changes are system changes which enable this to be sustainable. If that is the case, what's happening with those handover figures, why they're creeping back up? So what's your view as a board of how that's working on the ground?
I mean, I'll kick off and come to Deb. We haven't got it all right yet. We have made significant improvement, as you've described, Cabinet Secretary, and we've got a series of actions that we are taking that Deb can talk about in a little bit more detail, because we know that some patients are still waiting very long time in the department. So the 12 hours is a particular concern for us. And we know that we are still getting some concerning patient feedback about their experience of waiting long time in the department, although that is an improving picture. I think it is a whole system. It is the whole system pull, and the approach we've taken to ensure that we can de-escalate the department and pull our patients through. Liz might want to comment about my next patient bit as well as part of that process. So are we confident that we're sustaining? Yes, we are. What we're seeing is quite a significant increase in the activity at the front door, which is requiring us to gear up in terms of our responses and make sure that where we particularly have a problem over the weekend and on Sundays in particular, that we're making sure our response over the weekend is robust as it can be, to make sure that we start the week and end the week where we want it to be for our patients. But Deb, do you want to talk about some of the specifics that we're enacting at the moment?
Yeah, certainly. Thanks, Nobby. You're right, Cabinet Secretary, the last couple of weeks have been difficult, so we've been really proud of the changes that we've seen in the system since June, since we implemented the test of change, and really significant improvements. We know Morriston has been an outlier for many years in that respect, and the staff have worked incredibly hard. I think what we're seeing over the last couple of weeks is definitely increased acuity coming to the front door. So all of our clinical teams are reporting the patients coming in are more sick than they would have been. We've obviously been hit by IPC issues. Morriston's infrastructure is not brilliant for cubicles at board level or in the emergency department. So when we do get IPC constraint, it really does hit us. And some of the long delays we've seen in ambulances, a patient who needs a cubicle, we absolutely can't provide, and that's the safest place for that patient at that point in time. And that said, there's a graph in the pack which I think speaks volumes of the impact of long delays in beds against the escalation levels of the hospital. And you can see when our clinically optimized patient numbers are reduced, our escalation levels reduce accordingly. And we put that into a pictorial view so you could actually see the correlation between the two. So those are the three main issues that we're seeing that's resulting in the increases over the last couple of weeks. We're not an outlier over the last couple of weeks. We've seen that pressure across the whole of the system, because I'm literally looking at every 10 minutes to see what's going on across the rest of Wales. But that doesn't give us comfort. We want to improve where we are. I think the changes we put in are sustainable from our own system perspective and how we get the right things in the right place. So we've really recently put the single point of access at our front door. That is now starting to bed in. We've got WASP colleagues in there, we've got GPs, we've got social workers, we've got therapists all coordinated in that front. And that's fairly new. We're trying to see the success of that and keeping conveyances away. And I've also linked in with the crew of WASP to see if we can see the patients that we avoid a conveyance for, what the outcome for those patients is as well. So I think what we're doing is still all the right stuff. We're not going to change that at the moment. It's just how do we recover when we get that sustained pressure. And when we look at what goes on in the week, Abby's correct, it's generally Sunday into a Monday, we get that pinch point. We still don't have 7-day services. We know that's an issue for us and things will back up. And Monday and Tuesday have also been tricky, but we're recovering still far more quickly than we did before. I'm executive on call today, so it's looking better, thankfully. So that would easily. But then it's just repeating that. So it's getting that sustainable improvement in. The way we gauge it, so our feedback from staff is still really positive, particularly from our emergency department. We had significant concerns from particularly the nursing staff in ED. They now feel that the system is better and they can do the role that they need to do. It's just pulling those patients through in as quickly a way as possible.
How can you sound as Cabinet Secretary? You asked about the board's perspective on this. In October, the full board met with the full clinical team on ED. We asked them to talk us through how sustainable they felt the improvements were and what their ask was of us. And as Deb said, it's a flow issue. They are quite confident in the changes they've made through the test of change. They asked us particularly to help with your next patient, but it was the reason we are taking the risk. We're opening 30 beds first and then moving to 50 beds in Singleton with a very different staffing model to ease that flow in Morriston. And that's exactly what the clinical team asked us to do.
So when will that be?
Well, the first 30 beds are opening on the 5th of January, and we are taking a risk because we are in, deep into winter now. But this is exactly what they asked us to do to help the flow. And Liz and Richard are really leading on your next patient. That's what they asked us. They said, that's how you can help us sustain the hard-won improvements they made and was clinically led. We're all committed to do that. I think that's what we're doing. There's a little if you want to add on your next patient.
Is that right?
Yes, yes.
Sue, you will be familiar with your next patient, Jackie, and I'm sure you are as well. The key issue for us here is that we were holding risk in ED and holding risk in the community that patients couldn't get ambulances that they needed. So we now move that risk into the organisation, but it's how to manage and monitor that risk. We have very clear risk assessment processes around where the next patient goes, and we have oversight of that whilst they're there. We will need to surge at times. Our aim through all of this is to get the patient to the right place as soon as possible. And both Richard and I, actually at Quality and Safety Committee, we are specifically looking at the impact of that. What I want to emphasise really with the changes that we've made is the clinical leadership within it. You asked earlier around clinical leadership. You cannot do this without the engagement and without the input from our clinical teams. So the test of change in ED was clinically led. The way that we're utilising the flow processes is clinically led. There's more to do. There's always more to do. But it is about, as I said earlier, setting the expectation and working on that together.
Interesting.
So I asked this of the chief executive at the leadership board yesterday about when the acute hospital and the system's under pressure. Is that pressure felt in general practice, in the community, and throughout the organisation? So the bit here is how do you're right, the ambulances and the ED tend to hold the risk. And it's a bit about how do we federate that throughout the whole health board to reduce the risk everywhere rather than holding it in those two areas. So I just want to know what levers you've used for community general practice to help with this, so that when you're in open floor or business continuity, you're actually using every bit of the resource you have in the health board.
If we come on a couple of things, Debbie, you might want to contribute. So there are a couple of very specific things. So primary care are very good through the out of hours and the model care that we've got to contribute when we need to escalate with WASP colleagues to pull off the stack and to take any of the calls that they can out of the system and manage those clinically. And we do that regularly, and that's part of our escalation arrangement. And the other thing that we are very fortunate in having established the virtual wards where they're connected into each of the clusters. And we've adjusted the balance recently, haven't we, about looking at making sure that they are doing both step up and step down and reviewing that regularly about making sure we're getting that split right. But that gives us an ability to talk to all clusters and the cluster leads, the GPs who are operating in, about making sure we're maximising their capacity in the virtual wards and doing more to pull patients through the system, as well as preventing admissions that we don't want coming through the front door. And the fact that all 8 clusters are linked into that is a real asset that we are able to call upon when we're under pressure.
Yes, you might do it more regularly.
Yes.
Yeah, so in direct response to the question, no, I don't think it's fair enough, if I'm totally honest. There is always more we can do to spread that risk. I think your next patient was the start of that, because you're right. My invite was to the ward nurses cut down to see what it's like in ED when you've got one extra patient put on your ward, because there was sometimes 40, 50 additional patients in ED. So you've got to experience, I think, the heat to understand what it feels like there. And that's what we've done with your next patient. We try and do that more. So all of our huddles are across the health board. So it's not just Morris. It's easier Morris because everything is in Morriston because it's our only front door. So it's easy for everybody else to sit back there, Morriston again. So we make sure we bring all of that in. When it's at really heightened pressure at the front door, I really don't like seeing social media posts to say, please don't come to our ED because it's really busy, because it's the patients who need to come are the ones that don't. So for me, it's how do we convey that clinically and working with our single point of access, working with our boss colleagues, doing the staff reviews. That's how we gauge the clinical need and then going to make sure the right patients come in. So I think we're working really diligently to spread that responsibility and risk across the organisation. We touched earlier with bringing in Organised for Success. That changed our structure from a hospital-based structure to a service structure. I think that will help us in that space as well, because each of the service directors will have responsibility for elements of services that are now at Morriston, rather than it just be solely the responsibility of the Morriston team.
Thank you. So just a small extension of Jacqueline's point in that way. So your distributed risk model, I understand, in terms of distributing the risk across. How are you going to ensure that care doesn't happen in the inappropriate places, or that care is happening in the appropriate places? The first question. Secondly, you're opening at 30 beds. You just told us you had 170 to 190 people waiting for pathways for care delays. What assurances can you provide that this 30 or 50 beds to help ease the pressure in the ED won't stack up and suddenly become 210 to 150 pathway care delays? So I'm just wondering how you're going to balance that and what actions you have in place.
Part of the reason why we're leaving it to look at the January sale was to make sure we get it right. So there's a risk we could have done it sooner this year and perhaps given us some more space going into Christmas. Then there's a risk we did use that space again if we did it too soon. So that was one of the reasons as well. But it was really a case of getting the right staffing model there, making sure we've got the right cross board and social services support into there, and we pick the right patients to move. What we don't want to do is move the most complex discharges from Morriston into Singleton, because they'll just be a move for the sake of moving, and they'll just stay in Singleton at the same time. So what we're doing is we're allowing the clinical team to pick the right patients to move, with a view then, with that focused multidisciplinary team input, we can turn those patients around quickly. And the first part that we're going to do is move the surge patients, which are costing us a lot of money as well, to keep those surge areas open, so that reduce some of the financial burden. And then the next 30 we'll do will be hopefully to create a decant ward in Morriston, which will help us with our IPC moves as well. So we're really going to that. So first 30 will move the week beginning on the 5th of January. And then if we can cohort those and get those moving within that month, the next cohort will move there by the end of January.
In terms of the oversight, the Quality and Safety Committee and Jean and Liz are working together on how QSC will oversee and will make sure that the safety was safety. So Jean, I don't know if you want to say anything about QSC and how we're going to set about your oversight relation.
I'm keen to involve a few observations, if that's helpful.
We have very many new metrics that we're looking at. And as I said earlier, working with Liz, she is using metrics that are not only local, but we are allowing ourselves to benchmark against regional, national. And one of the things for quality and safety is that we absolutely, as independent members, understand exactly what is driving this potential cause of harm, and driving the use that we make of the feedback that we're getting from, I call it the shop floor, sorry, because of retail background, that we get from the shop floor, but importantly that we get from the patients and from their families as well. Liz, do you want to talk about the...
Well, I think there will be an opportunity to come on, it's not really further in the agenda, so for now we'll move on, but there will be a chance to come back to it.
Yeah, thank you, Cabinet Secretary. And I think, just relate to your point, Jean, I think you said it earlier that the complaints issues relate almost predominantly to access, timely treatment, delays, etc. And you've made enormous progress in reducing your planned care delays and maintaining the position of nobody waiting over 2 years. I suppose my couple of questions really. Firstly, the sustainability of this as we go forward with, we put additional money in, the money comes to an end at the end of March. Do you feel you can sustain it? You've got some local pressures with some of the diagnostic rates. So where are you with endoscopy and a couple of, I think MRIs going on a bit, and So where are you in relation to that, and how has all of that impacted your cancer treatments? Because gynae cancer in particular is really challenging. So I'm keen to understand the sustainability piece, but just on the complaints piece first. You've done all of this work, but you've got one of the worst complaints performances in Wales in terms of the number of delayed complaints. Your PTR, put many things right, performance 44%, I think it is. 300 delayed complaints. You're clearly an ex-retail, as am I, and interface with the public, dealing with complaints quickly is a surefire way to get the public on board, and you're not doing it. So I'm interested in why that is the case, but also the sustainability around planned care. On both those issues.
Yeah, okay, thanks. You're right, Nick, absolutely. We've got a backlog of complaints. It is a backlog and we are working through it, and we have a plan to clear that backlog by the end of March. In fact, I was meeting this morning to see how we do that. Complaints and investigations come into my portfolio. It wasn't within patient experience previously, and I think it has to have that lens on it. So it's the right place for it to be. So a plan to clear that backlog. The complex complaints we don't have huge backlogs with, but it's the very short kind of, we could process them differently. We've set about a test of change within Singleton Leaf Talbot and now being adopted within Morriston, which will mirror the listening to people guidance that's coming in, so that we make contact very early with our complainants. That's not going to help the backlog, but currently doing that will help not grow that backlog whilst we continue to bring it down. And listening to our patients. Feedback is one thing. What I would add to this, though, is also around engagement. And what we're developing is a much broader engagement strategy and plan, if you like, so that we can go out and talk to our patients and the public rather than waiting for that feedback, which is predominantly negative. We want to engage much sooner in our response, but also engage with our community in a much broader way.
Can I ask what the board's ambition is then for by when? By when, and what do you want to sustain?
From a complaints perspective, we will absolutely not have a backlog when we adopt listening to people in April. We're working with that now. We're already adopting the principles to ensure that we're responding in a much more timely way than we have previously.
I would bring this about it.
Yeah, I wanted to go back to an issue. Oh, sorry, apologies. I'm Isabel, the Chief Medical Officer. I wanted to go back to something that you mentioned at the beginning, which was the high rates of healthcare-associated infections, which are the highest in Wales. And I was wondering what oversight the board has in terms of addressing this issue and driving improvements. The evidence part that you shared with us mentions a number of improvement projects, but I was wondering, how do they come together into a plan, into an improvement plan, and what oversight the board has, and whether that is to the quality and safety committee, and how does that work?
If I say one comment, and then Richard, who's the lead executive for this, can comment in detail. I comment, sorry, you mentioned our integrated performance report. We're now reporting differently in terms of our performance, and we bring all of the domains together. And hospital and infections is one of the domains that we always have in our integrated performance gym. So it comes every month into the performance and finance committee, and it's elevated into a conversation board because it's one of the driver metrics that we are scrutinising in detail, because we are not where we want to be. And Richard, do you want to just comment on some of the things we're doing and some of the issues that we're addressing?
Richard, whether you wanted to say as chair of QMS, and I'll come in with detail.
If I can describe the systematic approach we have now to monitoring these kind of issues. We get the integrated report that Abby has alluded to. That integrated report gives us an absolute chapter and verse of where we are in terms of all healthcare infections. We then request Richard and any other executive or employee to attend our committees to talk us through exactly where that increase or decrease or plateauing has happened, then from that, we expect the execs to give us the information that tells us exactly what trajectory we're going to take to bring that into line. So the program that we've put together, which is I think we call it Gold Command program, particularly to look at seed efficacy, etc. Richard can talk to you about that, but we absolutely bring it to quality and safety report into board, and from a performance perspective, performance and finance also report to board on where that trajectory is going to.
The improvement program sits with me. The program sits with me as an IPC oversight group. And within that, I see that the CO Gold Command group, particularly I think issues at CTIP, which I'll come on to. And for each of our service groups, that IP&C group has a series of actions that they're undertaking that are generic for each, and some are specific for individual units in terms of their plans for reduction in healthcare associated infections. There are some specifics in there that we see. I mean, each of those, the 5 infections that we monitor, have different underlying causes or different drivers, and that's reflected in the actions that are being taken in the service groups. So, for example, for E. coli, it's predominantly been driven in primary care. That appears to be related to fertilizing people, care homes, and certainly over the summer was dehydration, which is very different from, let's say, C. difficile. On the C. difficile, which I think I say that is our main concern in terms of the numbers. We know historically that the population of Swansea has a background higher rate of C. difficile colonisation than often other parts of Wales, and that has translated into higher rates of infection in hospital. There are some innovations that we're looking at as well as what we'd expect in terms of hand hygiene complaints, compliance with antibiotic prescribing, where we largely do very well. For C prescribing, review of IV antibiotics in 48 hours, actually pushing that a bit further and looking at things like different sorts of cleaning products, different cleaning regimens on the ward, we take those duties away from the nursing staff and use healthcare to do that. And what's interesting in that in terms of the impact that's had, well, it still reflects as a higher rate overall for those infections in Swansea. If you look at, I think it's in the pack, if you look split that out by site, you can see where that has had traction, particularly on our less acute sites, with almost 50% reduction in need for health and single hospitals. The principal drivers are higher acuity site of Morriston, and some of the causative factors in there, including high bed occupancy, use of surge beds, lack of single space cubicles, etc. Which is why, as Deb alluded to earlier on, part of what we're looking at in terms of addressing our clinically optimised patients and creation of a decant facility, which we don't have, is critical, also in helping us drive down some of those infections.
Very quickly on that as well, how does the board oversee it? Each of our committees has a AAA report to the board, alert advisor sure. So do you make sure that the alerts come up to us on healthcare at every board meeting? And the board did make a decision, we have to bring back the decant board in Morriston. That's one of the key issues that we are bringing in as part of this whole changes.
Okay, thank you. I want to move on now, please, to the third item on the agenda, which is getting services ready for the future. Jan, who's going to be on that one?
If I may say a couple of words about the development approach, one of the things that we did on the public sector is resetting the overarching strategy, organising the organisation of staff that respond to theirs, because we have got a number of sort of enabling strategies, but we've lost the focus on what we're trying to deliver overall, so we've refreshed that. And I think at the heart of that is putting the population health agenda and using the really excellent population health plan we've got in place to flag it forward. I've touched upon the clinical services plan that's really important in terms of building in prevention as a key part of that. We've worked really hard on our Women's Health Hub. I know that there have been some challenges soon in terms of getting us there for very different reasons. We are trying to have a very novel approach to that because we know that many of our women tell us that physically getting access to places in public transport not when it needs to be. If you look at our deprivation, it's really difficult. So we are approaching this with a very novel lens around how can we deliver a different approach. It's taking us a bit of time to offer that out, but I'm really confident we're in a really good place in relation to that. And in this section, we've got maternity and neonates, but just I think what you were saying at the beginning, that we've got the perinatal review plan coming to our board in January. We've been making strides in terms of improvement. And then the final comment was just around our mental health consultation plan. Steve, I wonder whether you wanted to, as our vice chair with oversight of the mental health, say a couple of words on that by way of introduction.
Yeah, sure. So Steve Spill, Vice Chair, and as you know, Vice Chairs have an oversight duty over mental health and primary care. So our transformation programme has begun, albeit belatedly. We acknowledge that a previous capital rebuild and transformation proposal did not make any progress. We've now developed a phased approach. We've got an urgent estates programme which is currently going on to fix fixable short-term issues. We have an interim estates and service redesign in process, and the service redesign is in line with the All Wales strategy. That's getting underway currently, and work is beginning on a definitive longer-term solution. And mental health is now getting regular access to each of our board meetings, and so progress on each of the areas I just described will be reported to the board at each meeting. So I'll stop on mental health there.
Thank you. I want to ask you about the about maternity and neonatal services. Since the review, I know obviously that you've been implementing various measures, and I think information to improve the oversight as to speeding up access to training and staff morale. I think those are one indication of the positive steps which have been taken. But what I want to understand is how you've addressed the question of collective ownership across the organisation of this challenge, what that means in terms of governance, and how you are giving yourself the confidence that you have sufficient understanding of what's going on and the capacity to respond as a board to that and as an organisation to that, for you to have the confidence that the plan is one which can work.
Thank you. I'll start, and then a number of board colleagues will join the comments. As you know, Cabinet Secretary, both Abby and I, as Chair and Chief Exec, we are personally leading our response to this whole issue. And Abby and I are regularly in the service, talking to staff, talking to families. We make a point of doing that. In our board level, Waterford General, but the whole board understands all of the issues through the board development process that we have. We are currently pulling together for the January board all the different strands of our work, whether that's through the independent review, the FICE review, the family report, the engagement processes we have underway, the perinatal committee work we have underway, all the good practice that's going on, both in the birthing unit and in Singleton and out in the community. Independent members are out in that service regularly. We meet with the staff, we go on to neonatal. I mean, I myself was there last week. You visited as well, so you know exactly how good that unit actually is. So in January, we plan to pull the whole thing together, because sometimes we do forget in an actual formal board meeting just how much we all know, because we focus on making sure we're not an outlier, making sure that everything that's gone wrong in years gone by, we're focused on making sure that's not going wrong now. In the meantime, we are all conscious of all the good practice that's going on. So in January, that whole thing is coming together. All the awards, all the good practice, all the innovation. We're going to really take time at the January board, but board members are out and about with our staff, and we see every day. You know, we're very proud of them. They've come through quite a traumatic time. It's been traumatic for everyone, families mostly, obviously, but it's been traumatic for everyone. And we took great heart from the national conference we had on the 19th of November. All Wales was represented, and it was a showcase for a number of our staff. So that's how we do it. But there's quality and safety, perinatal. So I don't know how many people want to contribute to this. Do you want to start?
Can I just tell you what I'm looking for?
Oh, yeah, okay. Yeah.
So it's very positive to hear the individual commitment of board members to engage directly, so that's understood and is welcomed. I'm really trying to get a hand on how the board will know if it has the full picture. I don't mean that in any kind of, inappropriate way, but it's a huge issue for the board. You're clearly taking it seriously, so I'm not questioning that. What I'm asking is, how will you know if you're getting the data and whether early indicators of whether things are getting better or not? And what confidence do you have as a board that you are, properly able to challenge that from an informed perspective if things aren't heading in the direction we need to in the future?
So governance, which you mentioned, is a fundamental pillar within that, and working with the work that's already ongoing on an all-Wales basis, but also from a UK-wide basis, we have set up the perinatal committee, which I chair and which I have other representatives on. We see the data, and not just see the data and information, but we have the comparisons of where we are based on the national neonatal audit, based on national maternity information. How we utilise that data is to scrutinise. But your question was, how do we know? And we've been particularly interested in what's been happening elsewhere. We've particularly looked at the system of region signals that's just come into NHS England. Now, as yet, we don't have that in Wales, but we can take those principles. So looking at the information over time, utilising SPC charts in Houston, we can flag the areas that are of concern, and then we can interrogate even before it becomes an issue for us. We can use that information in an intelligent way, and our analytics team are working with us to enable us to produce that. And we are fortunate, Cabinet Secretary, that we've got some experts around us in our independent oversight panel. And one of those experts particularly has helped us to look at how we use our information to be able to alert. It's also really important that it's not just about data and information, it's also about feedback. And again, that engagement with our population, ask them how we're doing.
So there's a lot to discuss in this topic, and I just want to maintain kind of focus on discussion on it. So would you say that the board needs no other support at this point to be able to reassure itself that it has the capacity and capability, I would like the commitment to make absolutely certain that there are improvements?
You would never.
Okay, well, I'm interested in hearing what that means then. So what are you saying?
And I think focusing on the option that we have of using the experts that are around us, using our experts within Welsh Government as well to help us to interrogate and challenge what we believe we're seeing. And that will never stop, I don't think.
I think the other thing I would add, and Jonathan, we've had this conversation with you, Stu, and there are some areas where we haven't got quite the set of benchmarking data that would help us to know where we have some of it, the way that you're describing kind of through, but not for every point that we would want to monitor and track as part of the indicators of a safe service. So I think that would be a really helpful conversation at a national level. And we've also been exploring with the oversight panel the work that we're doing around building on the Birmingham model of triage that we've already got in place and strengthening that. And there's definitely a conversation about could that be a regional model, recognising that it is staff intensive to make sure it's comprehensive, and clearly you need more senior staff at the front end of that service to ensure we're responding appropriately. So I think there are a number of areas where we would really welcome a conversation around could we look at a more regional model of service, and where there are gaps in some of the benchmarking data that would really help us in terms of the suite of things that we are tracking and looking at. And just a final thing, I'm sure others want to comment. One of the things we do every week in execs every Monday morning is we've got the data from the previous week: maternity, mental health, planned care, cancer. It's not the fully validated data, but it gives us the raw data and anything that we need to pick up and have a further investigation of comes through those, and we get a lot of assurance that as part of the more formal reporting and governance into the board.
So when you talked about the triangulation you were using, you didn't mention staff in there, and And I suppose my question is, would your staff be happy to raise concerns with you early? And how would you know they would?
I would say they absolutely do. Our staff have been through this, most of our staff that have been there for a long time have been through this. And getting that culture and opportunity for them to be able to raise concerns, in many different ways is key to where we've got to now. And I know, and others that have visited, when we ask that question, they know how to, and they know where to go to raise those concerns.
Yes, can I just ask you on that? Because if you look at the 24 staff survey, it shows quite a low response rate. But the three main organisational priorities which staff identify is included speaking up safely. So how does that play into what you just told us?
Is that the overall staff survey?
Yeah. It is the overall staff survey.
Yeah. So I'm talking specifically around maternity, obviously, but I'm sure that Tina will want to read staff survey.
Just so there is the distinction to be drawn from the conversation around this maternity and the broader point which I've just made.
And there's a huge amount that we will learn from what we've been through in maternity, and I'm sure Tina will reflect that.
Okay.
Can I say, well, Tina, can I say, just to give you an example, I went to visit the ward, post labour ward. I did it in a twilight shift to catch them with the night shift coming in, because sometimes they just weren't night shifts, we don't get to meet some of those. And one of the things they did flag on the visit was their concern about the skill mix, and that's one of the things that has come through, by making sure on every shift we get the skill mix right, recognising that some shift we've got more really qualified than others and working that through. So that's just one little example where I felt they were very comfortable in raising that directly with me.
Great. So you say there was better practice there, perhaps than other parts of the organisation could learn from that. Is your argument? Okay.
Tina Ricketts, Director of Workforce and OD, just to say that the work we've been doing around early warning systems, so that around speaking up safely particularly. So we've developed a heat map. So I know exactly where I've got my hotspots in the organisation from a range of hard and soft metrics from the staff survey. And then we're targeting resources in those hotspot areas using the Speak Up Safely service, etc. But I know exactly where we need to put that additional support in place.
We'll come back to the broader conversation in the next feature.
Secretary, may I just add a point from IAM's perspective? Underpinning all of this is a fundamental cultural change that we have to bring about. And as independent members, when we're out there and we're talking, particularly as I don't have an NHS background, so my naive questions are genuinely naive questions. So I can ask people to help me understand what's going on, where it's going on.
So I guess this is just so I guess this is the point I'm getting at. So I understand how the executive team would have, an in-depth granular understanding, because that's what people would like to do, So, but I've been on the board in the context where I'm not an expert in the subject matter of that board, and it's a constant challenge thinking, but how do I know that I'm getting the full picture? I don't mean that in a disparaging way, but it's part of the obligations of being on the board.
It is, yes.
And so we've to hear from you how you feel, what confidence you have as I am is that you have that ability to get under the data, perhaps, or get that qualitative feel of what's happening in the organisation.
And you're right, there are two elements, the qualitative and the quantitative. For the qualitative with me, as an IM, there's a responsibility on IMs to go out and walk the floor. If they don't go out and walk the floor, particularly without an informed background, you do not know what's going on. So reports that appear in front of you at board, you probably will manage to read them. Whether you can read them and interpret what sits underneath them is very different. So for me, there's this personal responsibility to go out, forge the relationships. And I'm pleased and proud to say that staff have rung me on my personal number to ask me questions. Once you know that the staff can approach you, and they are approaching you, and they can trust you as a board member, an independent board member, that is a phenomenal step forward. How do I check that the data I'm getting is right? As I've said with this, particularly in the quality and safety, which we've reset, we ensure that
the metrics that we're receiving are correct in the first place. We're using metrics far better now across our service groups. So you have this marriage between a personal input and the input that you have that is delivered to you. If you were in retail and someone sent you a can of beans and you were looking for a can of peas, you wouldn't know until you'd opened the box. So you have to take that action in order to know what it is you're expecting to see.
Can I just ask about family engagement, please? So if I were looking at your board report, so your improvement plan, with a family member, how would I know that you're listening to families more? How would I know that you're taking it seriously and you're acting on concerns? And how would I know that as a woman or a birthing person or a family member that you're using me as an expert in my care?
There are many ways that we could do that, Sue. We're at the beginning of this engagement process, really. I talked earlier about feedback's one thing, but engagement is completely different. So how we would reflect that in our reports is how we've listened and what we've done to change things with that listening. I think we've got a programme of work that we're undertaking now, and you will see evidence coming through of the things that we've heard and what we've changed. Some of it has happened, but not on the scale that we want this to happen. I'm working alongside Ken, as you know, to help us to do that engagement. We've done our stakeholder map. We know the communities we want to go into. We know that they're hard to reach communities. Some of them we've been to, and some of them are now alongside us, helping to develop that improvement programme and the plans that we're undertaking. But there is more to do.
Can I just with the plan for family engagement here?
So yes, thank you. So the January board report will have the report from Ken Sutton, and Ken is looking at and advising us on the founding board concept, really, because we've used maternity and neonatal voices partnership, for example, up till now, etc. There are different maternity support groups out there. So Ken is designing with the team a series of sampling boards with different community groups across Swansea Bay and Iechyd, hard to reach groups. Abby has been to the mosque, been to the Chinese communities, been to hard to reach communities. So we are going to populate our population. Then different sampling boards. We're doing some really innovative things, like asking the Swansea Bay and Iechyd community voluntary services groups to go out there to their community groups to form part of these sounding boards as well. We're also talking obviously to Hamilton and Powers, because we have people coming from their areas. So we are going to have the overall approach to family engagement. And then we will have metrics that we will put on the side that. So we'll send you all the details of the January board report, because we are really excited about that. We've got a chance to do something really different here.
Thank you. Sally Ribbons, Director of Strategic Planning. I was going to ask a very similar question to Sue, but just to broaden it almost as a supplementary. If you take the learning from the engagement work that you've done with families and maternity, what are you taking from that, and how are you applying that to make sure that the voices of your patients, your workforce of your communities are really influencing your discussions and your decisions about service quality, service planning, service change?
Can I kick off on this? You might want to comment to our others. I think there are a number of different things that we've heard here. There's definitely one about how we respond, and so it comes back to the comment about complaints, which I think you asked Nick, around responding in a really timely way, picking up the phone and making sure that we're responding very quickly when the experience was not as it should have been, or something has been a poorer outcome. And we know that some of our processes in the past were not family friendly or women friendly in respect of that. And we've heard really good examples. There's nothing like sitting down with a group of families to understand that. There are some other particular issues. So again, the independent report talks very much about the proportion of our women who've got mental health issues. So understanding how we can properly support women through that pregnancy and birthing journey where they have a mental health issue. And also we've had really useful feedback from women with neurodiversity, and again, how we respond appropriately and support women who have different needs. John's talked about the Chinese Association, who are really keen to work alongside us. And hopefully working with our just running through the multiple leaders to make sure that we get our response right. And again, they are willing to share with us some stories to help train staff around the things that are really important, that are different. That those are really powerful, and we're using the Chinese community. We're very happy for us to have some case studies around just the cultural difference that makes such an impact. We're really aware, and I think some of the things that came out in the independent report, just recognising that one sentence spoken in a particular term or particular language can have really significant impact on a woman and how they feel in their experience. So we're using lots of different ways, Samir, but as you might want to add more.
We are using it in many different ways. So response is a key one for us. And we've changed the way that we're responding, and the involvement of families and women when we're investigating an issue or a concern that has been raised. That is already happening. There are many small changes that we make based on that information that we get and the understanding of how it feels. I think very clearly when we met with the Chinese Association, cultural differences were a key issue for those women. They're now alongside us, sharing that information and ensuring that it's a small community, and it's a fairly small community in Swansea, but however, the fact that they're there with us and we're working with those who are currently in the service with us from the maternity perspective means that we can work to get it right before something becomes an issue. I think that's absolutely key.
Thank you. I want to move on finally to the last of the 4 items that we are discussing today, which is how we are strengthening how we run the NHS. Jan, over to give a brief overview.
Yeah, and we've had to discuss this actually. So I will be really brief. A couple of people have mentioned culture in the conversation, and that's a real backdrop, and that goes to the work that we've done. So really building on our organised success programme that Tina's leading to make sure we've got the right organisational design and the right organisational structure, and that our operating framework is as it needs to be. John, I think you touched upon the introduction of care groups, which will give us a greater focus on some of the service areas that we're working through. We have made really good progress in terms of recruiting to some key areas. Our workforce plan, Tina, you're really giving a very different focus to that to make sure we've got the right people in the right roles, and they're really able to be engaged and to flourish in those roles. And we've got more work to do on that because the workforce as it's currently configured is not affordable in our financial envelope. So it's all about right sizing and right shaping the team as we go forward. We are working very hard with our partners in our trade union and staff side partners, and strengthened at board level. John, we've got a change in leadership there. We had good relationships before, but we're building on those. And I think Tina, you're really charging the way forward in terms of strengthening those relationships to the executive team level. I think we're also very aware, I think as you touched upon, staff being available to work. Sickness is a really big problem for us. We think we're not quite the highest in terms of the health boards at the moment, but we've got a real issue about needing to tackle with the long-term and the short-term sickness, because it is driving some of our variable pay. And again, some of that's cultural, but some of it's around making sure we're using our policies and processes very effectively. It is something that the performance finance committee drills into. So perhaps if you wanted to add a couple of lines in terms of how the committee is discharging its role in relation to that.
I mean, it comes under workforce scrutiny in particular. They're able to addressing really the cultural behaviour issues that drive that kind of system variation and cost variation and drive up variable pay. So in terms of unavailabilities, management of sickness, rostering, shift cover, and I know that it's that. Welfare is hugely important, of course, staff welfare critical, but at the same time you have to very robustly manage sickness management, etc., and make sure that all areas are following the policies you should be doing about, return to work and escalation in the face of high levels of other types of sickness. And I know there's Tina will come in on this. There's an enormous amount of auditing, etc., going on to make sure that those policies are being adhered to and they are being very robustly managed.
Can I ask a question? Sorry.
Yes.
So very right thing to do, but in my experience, actually, the staff who you want to actually use the policies aren't very confident in that.
Yes.
So with your answer, can you just tell us what you're also doing to support staff who you want to do this, the managers who are doing this?
Yes.
Can I also just say, just so that you could, I think the point Pat was making about the need to, the specific things that are being done about sickness, clearly they're not having the effect that you want them to have yet. So what's going on there?
So I'll start with that bit first if I can. So we set up a work stream under the Recovery and Sustainability Programme, which I'm responsible and lead. So we've got a real oversight over sickness absence. It's a wicked issue for the health board. We've had higher sickness absence rates through COVID than other health boards. So it is compliance and its cultural bit. So the compliance bit is all Wales policy, making sure we're doing follow that. We have had success in reducing our long-term sickness absence by focusing on those cases. However, we've seen the converse on the short-term sickness absence, so that's a cultural bit. You're right, Jacqueline, around the manager's responsibility. So I, as a line manager, have a high proportion of impact on the wellbeing of member of staff than they do with the person they live with. So it's about that compassionate, inclusive leadership, and that having making sure we've got the right leaders with the right skills and confidence to manage that appropriately, and that's what we're focusing around. For my heat map, I've touched on, I know exactly where I need to put that additional support in place. And we're doing that, and we are seeing benefits of where we put that in place.
That's good. Given that the response rate for this survey last year was 9% below the national average, so really at the very frankly worst end.
Yes.
How can you have confidence in the heat map and the
Yes.
data that you're getting, which obviously is crucial to you making those interventions? How do you know it's the
Yeah,
right
so
information?
The information is hard and soft, so it's all the what called the workforce, like the work staff turnover, 6 months absence rates, so the hard bits as well as the soft bits. You're right. So for me, a low participation rate in staff survey is an indication of staff engagement. So we know we've got lots of work to do around staff engagement, and people will not fill the survey in unless they can see what's going to change as a result of it. So we started on that this year. We've honed down on the 3 topics that you've mentioned earlier, and we need to say, you've said we've changed, we've listened. There's still further work to do. We have improved our participation rate this year, is just under the 19%, but we've still got a lot of work to do around this staff engagement, and that will be it's not something I can change overnight, but something that's where we're working to do.
Just on that, because I think it's a really interesting point you make about it is a measure of staff engagement, but it's a more corporate measure, isn't it? Because it's that whole organisation response rate, which is, what is it, 12-13% of organisations, 15,000 staff. They're not telling you what they think. And you're right, some of the questions are around, that engagement. But speaking up safely, I think the reference earlier, we're never going to get a culture of change and people being able to speak up until they engage in this process. So I just wonder locally, what could you do? Because that takes me back to one of my previous ones, where we used to do the exact thing, which was you said, we did, which gets them to, but you need to do it really, really locally, on a ward, in a department, in the estates kitchen or wherever it is. Because you talked a lot about changing the culture, and I'm not just relying on the staff survey once every 2 years, you're not going to change your culture. So what are you doing for that cultural change?
So I think we're doing lots of things, specifically in relation to the survey, and you said we did. There is the high level plan and actions that you've described and that we set out, but we'd also expect each team to have their own actions and be having those conversations with their local team. We are refreshing and updating how we communicate right across the organisation, because it is difficult, as you will be aware, across 15,000 individual staff, and making sure we get in touch in terms of communication. So we're trying to pick those conversations up, Nick, as we're out and about. We are, as an exec team, committed. We're based in Bagley, but we're really giving focused commitment to being out and about, more visible out in the patch and in the wards, building on the visits that the IMs are doing as well now, which were introduced. We introduced, I think, in the summer of last year. And there are plenty of opportunities. We have the regular midweek message that goes out, and I get a lot of response back from staff from it. We hold a monthly, I hate the term Ask Abby, and it's quite useful on Call Abby, so we can get alliteration, and that's variable uptake. But what I'm seeing, interestingly, is more frontline clinical staff joining that increasingly, and I openly invite questions to come, and I get them on the day beforehand, and we get them afterwards. And some of them are really tricky, and it's interesting. We put a big message out, upped our communications around the finances, and I can see people have read it.
Jan, I wanted to ask about something which has come up a lot in correspondence with me, which is in relation to lack of vacancies for final year nursing students. So that's an issue which is obviously addressing it all. On the other hand, although there's been progress, you're, as a health board, one of the top 3 highest agency spenders across the 7 health boards. So if I was one of those nurses, I would be thinking, well, that's my briefing was telling me here, so someone can tell me if this is incorrect. Well, maybe not for nursing specifically, but across the board. So my question really is, if I'm one of those nursing students, what might I make of the way you're planning?
I'm just going to start on it, then I'm going to hand over to Ms. Reed, because I think the board's been aware of this issue. In the past, we really haven't had within a workforce plan. I really accept that fully. So we knew we had an issue, and we were working through it. And then for this particular cohort in March, we were taken by surprise by shared services. They put the streamlining vacancies out. We weren't ready. The rest of Wales wasn't ready, and HIW wasn't there. We were still working through. So we knew we had to make that commitment, and we were simply on the back foot when it got out into the public domain. But the broader issue was that Tina's really putting that right through the integration of service, finance, workforce planning. We didn't have good enough planning, workforce planning at all. I'm going to hand over to Liz to say what we're actually doing now.
It is about that integrated workforce plan, and clearly there were things that when we planned, we assessed situations further ahead. There are things that affected this particular issue, so we've recruited really well. We're retaining better, all good for the health board. And also, I think that after retirement and the time return, we're keeping experienced nurses longer, and people are working longer. It did cause us some issues around the September cohort. We managed that. We did not have clear vacancies to offer adult nursing at the time. We did have mental health and learning disabilities, that wasn't a problem. What we've now done, as we were working through those issues, we've come up with innovative solutions really to be able to offer other students, because we want to. They're ours. We train them. We want them to be in our organisation to offer over 85 posts now, altogether with mental health and adult learning. We will continue to look at those solutions as we go forward, and it isn't just an issue here. It is an issue that we've discussed at EDOMS, and we're looking at that strategic solution going forward. I did go and meet with the students myself. I think that was really important to do, because I felt their anxiety. But I am really pleased to say we're in a very different place now, and we'll continue to plan for the future. But integrated workforce planning is key for us. We'll do that annually, and we'll do that longer term, and understanding the variables that are there.
Just to come back to the concept of this question, so have you resolved that issue with the current cohort of students through your planning for this year? Are you confident that they will get the place?
But I've had confirmation. Actually, it's something that's resolving. We have the ability to take 85 of the cohort. There were 16 from the adult perspective. We can offer all of those posts, and if there's any left in escalation, we know where we will be able to manage. But it has been a very different way of planning our workforce going forward to, have those
I just want to come back to, so shared services, open streamlining every year. It's been a good news for us, surprise, it shouldn't come as a shock to anyone. So we'll meet a week earlier, a week later, we shouldn't be on the back foot. So we should be able to, and you're talking about some failures in your workforce planning clearly, and this is a possibly extends beyond this health board as we understand it. So I guess my questions for you is how will you mitigate next year to not have an unexpected surprise? And what's going to be your sustainable solution? You talk about the concept of an integrated workforce plan. In the face of all the other pressures we talked about today, how will you achieve that and have something ready by the time the next cohort of students come around? Because that will happen really quickly.
Yeah, well, I'm sorry, can I add to that? And how will you be taking into account into that workforce plan the changes in model of service that we're seeking to deliver like a community?
I'll start if that's okay. So I started with the 5-year strategic workforce plan rather than an annual workforce plan. I think that's been the gap previously where we've just been short-term focused as opposed to medium-term focused. I've been looking at what's called top-down, so looking at our size and shape of our workforce, benchmarking that against others. And I'm really clear where we've got opportunity with the top-down perspective. We've also been refreshing our workforce plans from the bottom up, so each service have done a refreshed workforce plan. And now I'm bridging the two together, and we'll be really clear where we've got the overlay of the transformation of the services as we move into the new care group structure. So I've been taking regular reports through the Workforce and OD committee, and I will have a final strategic workforce plan ready by the end of March.
What about the picture next year?
So next year we're looking to reduce our workforce by 5%, so 900 whole-time equivalents in total. That will be delivered through reducing our bank and aid, our temporary staffing by 50%, which will equate to 300 whole-time equivalents, and then 5% reduction in our workforce in post. That will be managed through turnover and vacancies.
So the issue that Sue was talking about, the replication of this challenge for university students next year. What are you doing to make sure the situation doesn't arise again? I guess.
Absolutely. This issue can't arise again. That's what we've all talked about as a board. And so the way that we've approached it this time, we'll look to approach in very, very similar ways going forward. We are committed to our students, and to hear them was distressing. They were distressed. It was distressing. And we know the commitment we've made. We will work through our transformation programs, but also through our workforce plan to ensure that we can be in the right place.
We're doing something quite innovative this time, Sue. And Iechyd has commended us across the way about it. So we will build on that.
Yeah, and they've been incredibly helpful. They've been incredibly helpful. We've worked together, and we've worked with other health boards to look at what we can do. What we're doing is good.
Thank you for that. We've reached the end of the 4 areas that we wanted to discuss in this meeting. So before I sum up, there's a few moments. If there's any area that you want to draw to our attention that you feel we should know about that you haven't had a chance to do, or any closing remarks you want to make before I sum up.
Well, I'll be able to make a few closing remarks together if we make a canvas. So we did canvas that set out the key challenges that we know we have. We know where our performance is not acceptable. We know the trajectory we're on to secure improvement. And what we wanted to do was to give you and your officials confidence that we understand our agenda. We are all here because we are deeply committed to public safety. We are deeply committed to the NHS. We are deeply committed to the population of Swansea Bay and East Portalford. And we are ambitious, we are determined, and we have got a forensic focus on that agenda that we've outlined. And we're not going to stop until we've actually achieved it. And I will just highlight a couple of things that we didn't have a chance to get onto, which we're also working on.
Yeah, and I think just following on from that, Jan, we've done quite a bit of work both at board and at the executive team level about what the characters of high-performing, high-quality organisation look like. And we're on a journey. We are nowhere near there yet, but we know what that looks like, and we're building that into our organised for Success programme. I think some of the other things that are really important as part of that is around our regional work, particularly with Howard R, in terms of our regional models of care and our pathways. And I know, I'm sure that will come up in the topic of conversation when you met with Phil and Neil and the team last week. So we are strengthening those working relationships, and I think we're really keen to explore how we go much further with those. So things like how we would pull our waiting list across the region, and we're already making further step in terms of how we're operating around in this year's plan jointly with Howard R.
Can we have that? Sorry, just wasn't intending it. You've raised an important point about which is positive to hear, obviously.
Yeah.
Where you identify challenges which are common to both you and Howard R, so gynae cancer would be a good example of that. How will you address those challenges where capacity may not be available in that joined up?
I don't think on that one specifically.
So, I'll give you two examples, Cameron, second, because gynecology is one, but we've got another one, general surgery as well, which is a pinch point for us. So gynecology, I think it's fair to say previously the pathway in Howard R was stronger than the pathway in Swansea Bae. And the pathway in Swansea Bae is probably less sustainable than it needed to be because we run the tertiary services, and there's always a risk when you run the tertiary services that you oversubscribe into the tertiary level and you don't develop the strong DGH level service. And that's where we were with our gynecology service. So all of our gynecology patients were ending up with gynae oncology, so the very specialist treatment, which skilled the gynecology DGH level of that. So we've addressed that. We had significant workforce issues in the gynae oncology, which forced us to do that. So we're working with Cardiff collaboratively on the gynae oncology solution. We'll have a joint MDT in place by hopefully in January, and then a network solution going forward into 26-27. And alongside that, we're strengthening the DGH service in collaboration with Howard R. The PME rates are much lower now than they were, and we're working together to strengthen that DGH element of the service. From a Swansea Bae perspective, because we run the tertiary services for colorectal cancer in particular, we do all of our theatre capacities taken up by those high-end cases, which means we have very little capacity left. There are benign FGI type cases that we do, whereas Howard R are a very strong model. So again, we're working in partnership to say how can we work collaboratively. Our benign FGI cases can be done very well in Howard R, and we'll continue to do the colorectal, but also work to upskill the Howard R surgeons to some of the colorectal work they could do locally that they send to us. So we're looking at all the pinch points to see how we can work collectively to have sustainable DGH services, but also have the tertiary spread across the region where we can as well.
So are there I'm inferring from what you're saying that there are no areas where you feel there's a shared challenge where you need to do something very different? Do you think that between the two of you have, as it were, all the bases covered?
I think it's very different. There's some services have different pinch points. So when we started on the orthopaedic journey, Howard R was seen to be supporting Swansea Bae because we had the longest waits. We've turned that around between us, and now the regional model is actually supporting both regions collaboratively. Ophthalmology and eye care is another one. Howard R, we're very reliant on high-cost locums in their service, so we're looking at joint recruitments to how we can work together. They've got a better community service model than we have because they haven't had the medical model. So it's how do we share that learning and develop services that are more sustainable for the population?
Okay.
And I was going to come on to talk about Cardiff and Vale partnership because, as Deb has alluded to, some of the solutions are about a South Wales model of care. So we are really keen to look at cardiac service in particular. We are the second smallest cardiac surgery unit. We're very aware of that. The conversations which have been, we've been accelerating those conversations. I think we've had a series of evening meetings with the two teams, bringing our two teams together about how we might accelerate that work. I think the review that the JCC commissioned, we want to accelerate the timetable for that so we can get to a sustainable solution. And then the only other thing that, again, I wanted to highlight that we haven't touched on two things. We're working with Howard R around our digital implementation and strategy, looking at what we can learn from the model that they've got and bringing where we've got skills and expertise to see how we could have a regional approach to this. And then the last bit in the regional space is around research. Isabel, when you came to visit, we talked about research. We are really keen to make sure we are a very research active and health board. We know it's really good for patient care. We know it's really good for staff recruitment and retention. And we are increasing our relationships and strengthening and deepening relationships with both Swansea University, but the other two that play out in the regional programme, and they will be part of the regional committee going forward. And of course, we're going to have a very friendly finance director in Swansea University in the not too distant future, who will be working with us from a different perspective. Darren is moving on in the near future, but for us, we see real potential in terms of driving further income opportunity. We do some great work. Some of our cancer centre research work, we do really well in terms of recruiting numbers. I can't remember the name of the recent campaign, but I think we're something like second highest in the UK in terms of recruiting in. So really keen to make sure that's an active part of our programme. And hopefully what you've seen is that we know we've got a lot to do, but we are a team and a board that are really committed to delivering it for our patients.
Thank you, Abby. Thank you, Jen. Thank you to everybody for the discussion today and for the time. There are three things really which I'm keen we should all take out of the meeting. Firstly, on the finance performance, encouraging to hear a different approach to planning. Obviously, you see the benefits of that very quickly, and the progress in year needs to be very considerable at this point as well. Secondly, building on the work you started to do in maternity and the obviously to make sure that you have the support that you need as a board to deliver on the improvements that we all together want to see and that families want to see. And then thirdly, just the confidence level of the board in making sure the improvements in ET and the variability in some of those is addressed and the sustainability of that model for the future. But thank you all for your time. Diolch yn fawr iawn.